We're doing great.
Okay, so I guess we probably have to start pretty soon, right, Priya?
Means no more bagel talk.
We can't talk bagels right now.
I think we can go ahead and get started. We have a quorum.
Hey,
So
Howard, for our meeting, why don't you have some bagel and cream cheese sent in from Denver?
I can do it. Be careful.
free
Okay.
casual lunch.
Yeah, I get it.
So welcome everyone to today's MGH Neurology Grand Rounds. I'm Priya Srikanth, I'm one of the adult neurology chief residents, and we're very excited today to welcome Dr. Howard Weiner to give the MGH edition of the Tyler Lecture this year. And equally excited to welcome Dr. Marty Samuels, the founding chair emeritus of the Brigham and Women's Neurology Department, who neither of whom really need any introduction, but I'll hand it over to Dr. Samuels to give an overview of the Tyler Lecture and also to introduce Dr. Weiner.
Thank you very much, Dr. Srikanth. Can you put up the next slide, please? Somebody who can control the
I can
slides.
do it. I can do it.
So I'm going to be brief, and I'm not going to read Dr. Tyler's impressive CV, as many people do during introductions. I'm going to make this more personal because I want you to get a feeling for this remarkable man. The H. Richard Tyler Lecture has been endowed by, I'm going to call him Rick because he demanded that when I became faculty that I call him Rick and that I don't call him Dr. Tyler, so I'm going to do that. And the family endowed this annual lectureship, and we've started as Dr. Tyler wished and told me himself that his legacy, as far as he was concerned, were his family, his kids, and his academic family, the people he mentored. And we've started with a potpourri of those at the beginning of this lecture series with his son, Kenneth Tyler, the distinguished chair of the Department of Neurology at the University of Colorado in Denver, and the editor-in-chief elect of the Annals of Neurology. And then we had Dennis Selko, another one of Dr. Tyler's mentees, who talked about his work in Alzheimer's disease. And today, as you'll hear in just a minute, another one of Dr. Tyler's most mentees of whom he is most proud. And we'll give the lecture today. Dr. Tyler, Rick Tyler, was Brigham Neurology for 32 years. Actually, longer than that. That's just the period during which he was the chair of the department. From 1956 until 1988. It was a division of the Department of Medicine, and Dr. Tyler interned at the Brigham, it was then called the Peter Bent Brigham Hospital, and then was encouraged by Dr. Adams and Dr. Thorne, who were tennis partners, by the way. And over a tennis game, they decided that Dr. Tyler needed to become a neurologist. And they sent him over to Boston City Hospital, the cradle of American neurology, where Derek Denny Brown was the chair. And I won't even tell you all the other people that were there with Dr. Tyler, with Rick Tyler. They began to send Dr. Tyler over to the Brigham, where there was no significant neurology, to do consults. And then Dr. Thorne approached Dr. Tyler and said that he thought that he would like him to come over full-time and be the first real neurologist at the Peter Bent Brigham Hospital. In order to prepare for this, Rick Tyler made a European trip where he spent part of his time at the Queen Square Hospital in London, studying with Gordon Holmes and the other great luminaries there, and then at the Salpêtrière, which is the cradle of French neurology, where Charcot worked. He came back. He was at the NIH for a while, and then joined the Peter Bent Brigham and was there until he stepped down from the position 32 years later. And I want to end my introduction by just telling you the amazing way in which he handled the transition from one person leading the department to another person. Dr. Tyler had hired me. He gave me my job at the West Roxbury VA at the end of my neurology residency at the Mass General. And he mentored me and helped me to prepare to be his successor. And when that day came, he was so gracious, but not ready to quit. fully intact cognitively and very energetic. And so he had a second career, 20 years of seeing thousands of patients, virtually all of whom were dedicated to him and loved him and knew that no matter what happened to them, he would stick with them. I won't tell you about his research except to say that he was the person who figured out what asterixis was, and a very important metabolic encephalopathy sign in neurology, and many, many other contributions. But I think the person himself is more important to remember. Next slide, please. So today I want to introduce one of my oldest friends in neurology, and that's Howard Weiner. I'm also not going to read his CV. If I were to read his CV, that would take all the time. Howard has published over 600 scientific publications, if you can imagine that. And in addition, has done so much more for our community, both within and outside of neurology, including mentoring hundreds of people and fulfilling his dream of creating a multidisciplinary, multiple scientific center for the study of multiple sclerosis, and equally importantly, for the care of people with multiple sclerosis and related diseases. And I would say that although I'm biased, I think it's far and away the most impressive center of its kind in the world, and I think most people would agree with that comment. I'm not going to tell you about Howard's research because I'm going to let Howard tell you himself. But if you put up one more slide, I want to end with this. That's Howard Weiner with Martin Landau, the great actor, who made his last movie with Howard Weiner as the writer, producer, and director, called The Last Poker Game, in which he and Paul Sorvino, another great actor, played two very moving parts in dealing with the existential factors of aging, something that many of us are facing ourselves. Howard has been very interested in existential issues beyond neurological medicine. His interests are very wide and deep, and he's been a great friend of mine and allowed me to do my clinical work by supporting the great science at the Brigham for all these years. So it's my great pleasure and honor to introduce my old friend, Dr. Howard Weiner, who's going to tell you about his work.
Marty, thank you very much. Here's the disclosure and accreditation statement. You don't have to read it, but there it is. And here's, it's a pleasure to give this talk. And my chosen area has been immunology, as it stemmed from MS, but it is really broadened to all neurologic diseases. And that's what I'm going to talk to you about today. Now, in 2004, I published a book called Curing MS, How Science is Solving the Mysteries of MS. We've come a long way since then. But now we're struggling with many other diseases, and I have another book coming out. It'll come out in October, and it's called The Brain Under Siege. And here we talk about 5 of the biggest diseases: Alzheimer's, MS, Parkinson's, ALS, glioblastoma, where we are, how we can solve it or not solve it. And there's a lot more to learn, so I just want to tell you about that. Now, one of the things that I did in the book is I talk about the brain as a crime scene, because this is for the lay public, but it's pretty detailed scientifically. And when you look at neurologic disease, you look at the brain as a crime scene, and you have to solve that crime scene. Why is it there? What's going to happen? And actually, we now have a studio and producer and director, and The Brain Under Siege is going to be made into a 6-part docu-series. So I may be at the Mass General filming people there. So let's go into neurologic diseases. This is a picture in the book. These are the illustrations we have, the crime scene in relapsing MS, and the artist was very clever. She made a little scope here looking at the crime scene. And in MS, you have the big part of the crime scene in MS are all these T cells and macrophages that come into the brain, and of course, the various plaques. So the big question for every disease is if you're going to treat it, what causes it? And for MS, there was a long interest in viruses. No one ever found an MS virus. We know genetics play an important role, specifically immune response genes. We know the environment now plays a very important role. Vitamin D, smoking makes MS worse, and I'll talk about the gut. Some people argue that it's a primary degenerative process, but I think that's very unlikely. And MS is really considered an autoimmune disease. Now, we've learned a lot about the immune system, and this is where we are in 2021. And in multiple sclerosis, you have effector cells, Th1 cells, Th17, CD8 cells. They go into the brain and cause inflammation. You have regulatory cells, many types of regulatory cells, FOXP3, TR1, et cetera, and they act to counter this. And we have about 15 FDA-approved drugs for MS, and all of these drugs work on these particular pathways. Now, one of the big breakthroughs in MS is that anti-CD20, it has a dramatic effect in MS. We can't go away from that. The question is how to, and we're treating all of our MS patients, many with anti-CD20. Interestingly, we're finding some of them aren't responding to the COVID vaccine, which is a problem that we have. And the question is, how do the B cells work in MS? And there's many possibilities. The people who originally did it thought that it had to do with antibodies, but we now know that the B cells are working by antigen presentation. They are presenting antigen in a way that leads to a pathogenic T cell response. So then we come to the next crime scene, which is progressive MS. And progressive MS is different. You have a shrinking brain, you have cortical demyelination, and rather than T and B cells and macrophages, you have astrocytes that are causing a problem, microglial cells, and that's why the drugs we use don't work, because they don't work on the brain crime scene as we see them here. And the mechanisms of progressive MS are twofold. One is immune dependent, involving cells in the nervous system, microglia, astrocytes, et cetera. Others are immune independent, and it's very hard to treat these immune independent factors, and so we're working more on the cells in the brain. Now, if you go back in time, and this is now a paper that was published in 1983, when there was a big debate whether MS was caused by a virus or caused by the immune system, and this is a now classic paper published with Steve Hauser, who was at the Mass General. We were at the Mass General together. Jim Larick was there, so Beal, et cetera. And we found, and we published that high-dose cyclophosphamide worked in progressive MS, and we also tested plasma exchange. Now, if you go back in time, here's a picture. I actually underwent plasma exchange because our patients were afraid to do it. I wanted to show them it was okay. Here's Steve Hauser, 1983, David Hafler. Here I am, and this is almost 40 years later in a meeting. Myself, Steve, and David, I think it's a dramatic picture. I'm happy to say that all three of us won the Distal Prize for Multiple Sclerosis Research. So we started off here. Steve obviously was chair of neurology at UCSF. David is chair at Yale. Now, everything is not always as good as it seems, and Marty will remember this because the Canadians, John Noseworthy and George Evers, published a trial and said cyclophosphamide didn't work in progressive MS. This was very disturbing because we saw it working in people, and they weren't the nicest people when they presented this work, saying that we didn't know what we were doing, et cetera, et cetera. But the biology of what everyone was doing is right, and it turned out that we were right and they were right. And the study that began to explain things is a study by Henry McFarland, where he did a study. Now, this is 16 years after we published our paper on cyclophosphamide when people were treated. And he showed that the pulse cyclophosphamide really dramatically helped by MRI on these patients. Now remember, the MRI was crucial in understanding MS. And then we found that the treatment of progressive MS related to the duration of progressive disease. And one of the reasons that we saw something is what we called progressive disease was actually had a big inflammatory component, and they were looking at late progressive disease. And so now we know that when MS changes from relapsing to progressive, the immune system changes and you get a compartmentalized response in the brain. And here's a picture of the immune status and course of MS. In relapsing disease, you have adaptive immunity, and these are gadolinium enhancing. And when you move to progressive disease, there's microglia, astrocytes, monocytes. And in this sense, secondary progressive MS begins to turn into processes that you see in Alzheimer's and Parkinson's and ALS, et cetera. Here's an EAE experiment that I think illustrates this point. This is a progressive model of EAE where they have an attack and later they become progressive. And if you deplete the activated astrocytes during the acute phase, the animals do worse. When you do it in the progressive phase, the animals do better. So this shows that the astrocytes are good in the acute phase and bad in the progressive phase. I'm hearing some noise. I don't know if other people hear that noise. So one of the big things in MS that we're working on is developing biomarkers for MS. One of the biomarkers we're working on are called antigen arrays, done by Francisco Quintana, where you put all these different antigens on a plate and look for antibodies. And we actually find different antibody patterns in relapsing disease from normal controls. And it's also different in progressive MS, so that you can see in the periphery that the immune system has changed. The other area that we were looking at are microRNAs, which are found in the blood, and everyone knows about microRNAs. And there's also a difference in microRNAs from relapsing to progressive disease. And here's some of them, as you can see in the disease process. And we're trying to come up with a serum antibody and microRNA signature for disease monitoring, disease risk, and discovery. And these biomarkers, the idea of biomarkers in personalized medicine is very important for Alzheimer's disease, ALS, Parkinson's disease, and we're all trying to look for that in the blood of these patients. One of the biomarkers that has become very interesting in neurology is neurofilament light chain, which are in the axons of neurons, and they go out into the blood. We just wrote a big review of neurofilament light chain, and neurofilament light chain is in many, many neurologic diseases: MS, Alzheimer's, ALS, Parkinson's, stroke, traumatic brain injury. And it's sort of become a classic way to measure brain damage. Now, many things can affect it: peripheral damage, CNS damage, because it's cardiovascular effects can help it. So because it's so protein, you have to be careful when you measure it.
Howard, I'm sorry to interrupt you, but somebody is not muted and people are having trouble hearing. So everybody, please check to make sure that your microphone is muted, because there's noise in the background. Thank you, Howard. I'm sorry to interrupt.
That's okay. Yeah, I was hearing some of that myself. I don't know if you can mute it centrally. Priya, can you mute it centrally?
I can't because I'm not a host, but you may be able to. It may be coming actually from Carol's computer if you're able to just mute it.
How do I?
I think Carol's is the host. So
Sorry.
I'll try to, Carol,
I think she's muting it now.
mute it.
Yeah, okay.
All set.
Thank you very much.
That's
Thanks,
it,
Marty.
good.
So a major new area that we weren't studying when we were treating with cyclophosphamide, and has become a major area in all of medicine, and especially in these neurologic diseases, is the microbiome. And we all know about the microbiome and how important it is. The microbiome, in terms of interaction with the gut, is very important. And the microbiome can affect, it can release cytokines, it can affect the immune system. There's communication by the vagus nerve. And this area is just exploded in terms of studying neurologic disease. It's something that we've become very involved in. And let me show you a little bit about the microbiome. A big study in EAE was they took germ-free mice. And these are mice who are under, and the germ-free mice don't get EAE. But if you colonize them with the microbiome from a normal animal, then they get EAE. So the microbiome may be driving the disease. This is a paper that we published where we found alterations in the gut microbiome in MS. We found disease-related changes. One of the two bacteria we found is Akkermansia and the butyrates, which become very important. And in unpublished data, we're now looking, because we're very interested in progressive MS, we're looking at the microbiome in progressive MS. Now, this is very complicated. You got all these bacteria. Remember, we had to learn all the nuclei of the thalamus. I'm having to learn all these, how to pronounce the name of all these bacteria, Clostridia, Enterobaceae, et cetera, et cetera. But we find that some aspects of the microbiome are increased or decreased in progressive MS. We hope this will be coming out of the Annals of Neurology soon. We just submitted the final review. The interesting thing is that we actually find that the microbiome correlates with EDSS in MS. And we find that Clostridia is important, Akkermansia is important and can help in other diseases. It can also be associated with MRI changes. And Akkermansia is associated with low lesion volume and a higher deep gray matter volume. So we think that Akkermansia may be something that we could target or treat in progressive MS. And interesting, we also found a microbiome associated with quality of life in MS, which could relate to the various things that these microbiomes secrete. Now, one of the other aspects of progressive MS, and this is true for all the other diseases, ALS, Alzheimer's, is there's more microglial activation, and this is work done by Tarun Singhal at our center, and there's more microglial activation in progressive versus relapsing MS. So one of the things that we did is we transferred feces from relapsing versus progressive MS and looked at them in animals. Now, Koch's postulates argue that you could find something and that it affects the disease. So with the microbiome, you can transfer the microbiome and see what it does in animal models. And actually, the progressive MS microbiome actually modulates microglia. You can see that it changes and it's different between relapsing and progressive MS. Now, how can you use the microbiome to treat? There's a number of ways you can treat. Probiotics. People have been investigating fecal microbiome transplant, and we actually were thinking of maybe doing it in MS. We're working with people at Mass General, Katie, at the Mass General, Katie Nicholson, but the FDA is not letting a lot of these things go forward. So we probably will go back to probiotics. But if we discover metabolites, and I'll tell you about fecal microRNAs, that could be used for therapy. We did a study of probiotics where we took a probiotic mixture and we gave it to MS patients. We took healthy controls for MS patients. We gave them a probiotic for a couple months, and then we did a washout. And in fact, we actually saw changes in the microbiome. This is the probiotic formulation. We actually also found changes in gene expression, and we found increase of IL-10 and other anti-inflammatory genes. So we're aiming where we're headed with the microbiome. We ultimately want to identify specific bacteria in the gut of patients with MS, Alzheimer's, ALS, and see whether we can treat. Now, one of the discoveries we made, which was kind of unexpected, is that the microbiome has fecal microRNAs in it. And we looked at these different microRNAs and found that there's a microRNA called miR30D. That's increased in the feces of EAE animals. And it's also increased in untreated relapsing MS models. You can see that this microRNA is increased there. And so we then made an oral, a synthetic miR30D, and it actually works on established EAE, and it actually works by increasing Akkermansia. So one of the ways we're working is to try and take take microRNAs, synthesize them, give them orally, and see whether we can treat the disease. And this is the Akkermansia study. I'm not going to show data here, but there's also data on the ketogenic diet and seizure medication. And Akkermansia may play a role here in terms of seizures. And we're actually talking to people at the Brigham to begin looking at our seizure patients and the microbiome. Now, here's a nice picture. You don't know what it is, but this was taken in Vienna. This is my grandfather. This is my mother and her sister. This is my mother as a young woman. I'll tell you, she's beautiful. And here she is older. I can tell there's something wrong with my mother here. And the problem with my mother is that she had Alzheimer's disease. And we lost her to Alzheimer's disease. And she says to me, Howie, you're a brain doctor. Can't you help me? Well, I couldn't. But let me tell you how we're studying Alzheimer's disease. I showed the picture of my mother because nobody in any family does not suffer from these diseases. Merritt knows I had another family member with ALS that we looked at. So we really need to find treatments for these diseases. Here's a crime scene in Alzheimer's disease. The big deal in Alzheimer's disease are amyloid plaques, neurofibrillary tangles, and also microglial inflammatory responses. Now, I'm not going to talk about anti-A-beta therapy with antibodies that Biogen and other people are doing. I'm going to talk about our immune approaches. Now, in Alzheimer's disease, there's two aspects of innate immunity in Alzheimer's disease. One is the monocyte, and another one are microglia. So I'm going to show you things that we're doing with monocytes in Alzheimer's disease and with monoclonal antibodies. Now, in the year 2000, or a little bit afterwards, they were trying to treat Alzheimer's by immunizing with A-beta peptide. And it turned out that the people that they immunized developed something that looked like EAE. So of course, that's right in my bailiwick, EAE, and these patients developed what looked like encephalomyelitis. So we studied EAE in an AD mouse model. And did we find whether these APP mice are more susceptible to EAE? And could you cause EAE with immunizing with beta amyloid? What we found, to our surprise, although I guess it's not surprising now, is that if you gave animals EAE, you cleared the A-beta from the brain. Now, this is done 15 years ago. And of course, you can't treat people with inducing EAE. And so we did a lot of work and found a nasal proteasome, an adjuvant that you could give nasally and it would prevent amyloid deposition. This is what the proteasome looks like. It's been used in flu vaccines. It's a mixture of outer membrane peptides from Neisseria and LPS from Shigella. And when we gave nasal protein, either to young or old animals, you can see that you really decrease the amount of amyloid in the brain. And this works by peripheral monocytes coming into the brain. These are GFP chimera mice, where you can see the monocytes coming in the brain. We treated them with nasal protein. Here you can see we treated them with nasal protein. And you can see the monocytes come into the brain and they clear the A-beta. And now, after all these years, this year at the Brigham, we're going to do a human trial of nasal protein in Alzheimer's disease. We'll measure that's my clock going off. We'll measure the amount of A-beta in the brain. And we're going to do a dose ranging study to see exactly how that works. It also tells you how long it takes to get to clinical trials. There's another group actually that is using checkpoint inhibitors to activate the immune system and to treat Alzheimer's disease. Now the microbiome changes as we get older. And let's look at microglial cells. This is homeostatic microglia and neurodegenerative microglia. This is work done by Oleg Butovsky. These are different types of microglia. And we found that if you give Alzheimer's mice antibiotics, you reverse these, the MGND or these neurodegenerative microglia. And you can see the changes here. And you then can find a strain of bacteria that reverses the microglial neurodegenerative signature. Here we give Faecalibacterium and ApoE goes down, which is a measure of neurodegenerative microglia. And it also reverses the cortical age-related gene expression. You can see how this, these are the inflammation of the brain, and then when you give the Faecalibacterium, it goes down. Bacteroides is increased in aging. It's increased in aging humans and also AD patients. And actually, if you give bacteroides, it increases A beta deposition in APP PS1 mice. You can also modulate microglia with transferring. Here's another experiment where we give microbiota from an AD patient, and we give it to an animal, and you can see you have a decrease in the activation of the microglia. So when you look at Alzheimer's disease, when you look at Alzheimer's disease, there's different ways that the microbiome can affect. You can give specific microbes that affects A beta plaque formation. It can affect neurodegeneration, and it can affect peripheral macrophage recruitment. So the microbiome reacts with all these different things. Now, microglia can be good or bad. This is a very interesting paper. And early, it appears that microglia are good to help prevent Alzheimer's disease. Later, they can be bad. So you have to figure out when you want to modulate them. This is other work by Tarun, and PET imaging shows activated microglia in Alzheimer's disease. Let's turn to ALS, which Merritt really has developed so nicely at the Mass General. And Merritt was very kind to help me with my book and review it and at the Healy Center. And the crime scene in ALS is interesting. Obviously, we know it affects the motor system. And you have all these metabolic dysfunction with SOD mutations, C9orf mutations, et cetera. But there are problems with astrocytes and microglia in the peripheral immune system and the microbiome in ALS. So let me show you what we're doing with ALS. And one of the things we looked at in the animal model is we looked at splenic monocytes in animals, and we found that miR-155 was increased. And if we treat with an anti-LY6 antibody, ALS animals survive longer, which is very encouraging. And actually, if you look then in the spinal cord of these animals, you also find that there's increased miR-155, and you also see this miR-155 in ALS patients. So that you have this inflammatory process going on in these animals. And if you ablate animals with miR-155, you can delay the onset of SOD. And we're hoping to ultimately treat with an antimir to treat the SOD, to treat Alzheimer's disease. ALS. Now, interesting, of all the diseases, if you give antibiotics, it makes ALS animals worse, the SOD mice, where it makes all these others better. And this is work that we did where we gave antibiotics, and we found that these ALS animals actually survived longer, so that the antibiotics are doing something, and it relates to the production of butyrates. So as we were working on this, sometimes you get scooped, but that's okay. A beautiful paper came out in Nature talking about the gut microbiome, showing what we found and how when you give antibiotics, the SOD mice do worse. And actually Akkermansia can help the motor function, and nicotinamide can help the motor function. So this is a way that we might treat with Akkermansia or with butyrate producing bacteria. This is Katie Nicholson. We have a great collaboration with Katie and people at the Mass Generals. and we're going to be looking at the microbiome and how we can treat and study the microbiome in ALS patients. Here's an interesting experiment. If you co-house wild type animals with SOD bacteria, you affect these microglial neurodegenerative genes. So now I'm going to keep going here, and I'm going to talk about something called nasal anti-CD3. This is something we've developed for a while, and we found that if you give nasal anti-CD3, it induces regulatory cells, affects microglial cells, and we're beginning to apply this for a number of neurologic diseases. And so here's the basic experiments where we gave nasal anti-CD3, and it halts EAE in a progressive model. You can see that here. The anti-CD3 doesn't go in the brain. It actually stays in the cervical lymph nodes. It protects the animals from injury, and it affects microglial cells. The nasal anti-CD3 regulates the inflammatory phenotype of microglial cells. So the T cells are going into the brain, affecting microglial cells. They're also modulating astrocytes. You can see IL-1 goes down, osteopontin goes down, and it's related to IL-10 because if you block the IL-10 receptor, you get you reverse the effect. Now we're looking, because the microglia are important in other diseases, we're looking at other diseases. And actually nasal anti-CD3 reverses the aging gene expression in wild type mice. And when we treated Alzheimer's mice with nasal anti-CD3, you could see that they performed better on short-term memory. And we also looked at nasal anti-CD3 in the microglia of SOD mice. And when you give the nasal anti-CD3, this also affects the microglia here. And we did a pilot experiment giving nasal anti-CD3, and it actually appears to have an effect in the SOD mice. These are just early experiments. So we wanted to translate this, and so we now have given nasal anti-CD3 in healthy volunteers. It's called furalimab. We gave it at 3 doses, done by Tanuja Chitnis and Claire Beecher-Allen, and we found no toxicity, and we actually looked at immunologic effects. So we're ready to move it into patients, and we will treat our first progressive MS patient with nasal anti-CD3 this year. We've also been talking to James Berry about treating ALS patients and treating Alzheimer's patients. Now, unexpected to everyone, we got COVID, and as we know, COVID has this secondary phase where you have a hyperactive immune response. So before even treating MS, we carried out a trial. This has not been published, but we finished it, where we gave the nasal anti-CD3 in mild to moderate COVID patients in Brazil. And we just submitted this for publication. And what we did is we took these people and we randomized them to placebo, furalimab with dexamethasone, or furalimab alone. We treated them nasally for 10 days and gave them 100 micrograms. Here you can see the experiment. And actually we found a decrease in inflammatory blood markers with the nasal furalimab. Here you can see the IL-6. This is reduction, the IL-6 beta reduction, the CRP induction. And they also found more rapid clearing of lung inflammation. This is some of the lung inflammation you see in the furalimab here, furalimab treated patients. And what it really did is you had more improvement in the control patients. 1 out of 8 improved, marked improved. The furalimab 6 out of 8, 5 out of 12. Now this is clearly only a pilot study, but it showed something. And we're going to do a treatment with more severe patients with the nasal anti-CD3. So it just shows how you never know what you're going to end up studying. Here's the crime scene in Parkinson's disease. I'm not going to spend a lot of time on Parkinson's disease. We know about alpha-synuclein, Lewy bodies, etc. And we are studying the microbiome in Parkinson's disease, but just to bring to everybody's attention, there's a classic paper published in Cell from Sarkis Mazmanian showing that the microbiome can affect Parkinson's disease by affecting microglia. And if you take microbiota from Parkinson's disease and give it to animals, they get more motor dysfunction. So the last disease I'm going to talk about is glioblastoma. This is the crime scene in glioblastoma, a terrible, terrible disease. It just is a mess. It just is a mess. And Ted Kennedy died of glioblastoma. John McCain died of glioblastoma. Joe Bidenson died of glioblastoma. And we really have a hard time treating these patients. Let me show you something we came up with as far as treating a checkpoint inhibitor. So this came from our studies of oral tolerance. In an immune cell has TGF-beta. LAP is something on the surface of the immune cell that suppresses the immune system. And we were studying LAP in immune tolerance, giving anti-CD3 antibody and studying different subsets. And we found that LAP is also very important in FOXP3 T cells, and they're overproduced in colorectal cancer. And we found that TGF-beta induces surface LAP expression and that it reverses oral tolerance. But then comes a question, could this checkpoint inhibitor that affects LAP be effective as immunotherapy in tumor models? And the answer is yes. So here you have GBM, and you can see increased survival in these animals given with the anti-LAP antibody. And we tested it in a number of anti-tumor immunities. And if you target latency-associated peptide that we studied because of oral tolerance, it promotes anti-tumor immunity. Now, as it turned out, Merck liked the idea, and they bought this company that licensed our antibody to treat people with anti-LAP. Now, I came back, this is when you could travel, I came back and I saw this woman holding the sign that said LAP. I said, oh my God, does she know about our work? But she's welcoming people from the Los Angeles Philharmonic. The other diseases that we could study immune mechanisms, epilepsy, stroke, antibody-mediated disease. And with Tracy Batchelor, we're trying to expand our work on immune-mediated disease and applying immune mechanisms in neurologic disease. Here's the lab before the pandemic. Here's Yoda working on Protalin, Stephanie probiotics, Rafa anti-CD3, Thais is from Brazil. She ran the Brazil trial. Lori Cox, our microbiome expert. Shirang did all the the MIR 30D experiments. This is what our lab looks like during the pandemic. We couldn't meet inside, so we had an outdoor meeting on the quad. We're all wearing our masks. Now we're vaccinated, so we don't have to wear our masks necessarily, but we're keeping ourselves 6 feet apart during the pandemic. Now, Marty mentioned that I was interested in more than neurology, but the brain and other things are important. So I did make a film called What is Life, where I go around and ask life's big questions. Is there evil? Why is there a God? And all these questions. It won some Los Angeles Film Awards. If you want to watch this film, it is on YouTube, and you can just go on YouTube and watch What is Life, the movie. Marty also mentioned my other film with Martin Landau, Paul Sorvino, and Maria Dizia. It was originally called The Last Poker Game, and they said, we got to start the name of the film with an A because it comes up faster when people search. So it's called Abe and Phil's Last Poker Game. It was the Tribeca Film Festival. These two guys are old guys who meet in a nursing home and talk about life. She's looking for her biologic father. She meets these two old guys. They both want to be her father. Martin's wife has Alzheimer's disease. Martin actually passed away, as Marty said, but he was at Tribeca and was able to see the film. Here's a nice review by Martin Landau, gives a quietly powerful final performance. Pete Hammond is a big guy in Deadline Hollywood, so I was very happy to get this great review. I won't show you the bad review I got in the New York Times, but I will show you all the good reviews. It does say here, featured debut of Howard Weiner. I'm an eminent neurologist, so that's very nice. Here I am at the Tribeca Film Festival with a very famous actor who you all know. And here is our red carpet for Abe and Phil's last poker game. Now I'm going to end by doing a quiz and giving some advice about life. So here's a question: which famous politician won a Nobel Prize in Literature? Now, when we are in person, I can have people raise hands. Franklin Roosevelt, Winston Churchill, John Kennedy. This is in literature. And actually, the one who won the Nobel Prize is Winston Churchill. And Winston Churchill had various advice that he gave. And I'm going to give this advice to everybody, including myself, as we struggle with disease, with the pandemic, with all the different things. So number one, Winston Churchill said, aim high. So I think we need to aim high. Don't be afraid to go for big questions. Don't be afraid to answer big questions. He also said that you have to work very hard. So I think there's nothing like hard work. And this is something that we all need to do. He also said, don't quit, be resilient. And Merit will know of all the trials in ALS that haven't worked, all the trials in many diseases, in Alzheimer's, MS, we were luckier, but you never quit because ultimately we're going to succeed. Another thing he said is don't hold grudges. And I think that's good. Sometimes you hold grudges, but you can't always go by this. I'll tell you a story. My mother, I showed you a picture. She said, as she got older, Howie, don't hold grudges against people. That's no good. So I said, hey, Mom, what about Uncle Henry? What about him? Oh, no, I mean, Henry, never talked to him again. What he did to your father was terrible. So it's easy not to say something and not do it. And finally, Winston Churchill said, enjoy life. He was a painter. And I think we all need to enjoy life as best we can. Here we are at the Ann Romney Center for Neurologic Diseases. Here I am on CNN when we launched the Ann Romney Center. Of course, all they wanted to know is about the presidential campaign. They didn't ask me any questions, but thankfully our country is doing better. And I always end my talks with the word hope, because I think there's a lot of hope. The neurologic diseases we study are terrible diseases. I'm very lucky that in my lifetime, I've been able to really see a lot with MS. I don't personally take credit for it. I think it related to the field moving and the immune system understanding it. I'm glad I could be a part of it and build up a big MS center. I'm happy to say there's a big prize in MS, the Distal Prize, and it's won by myself, by Steve Hauser, by David Hafler, and now by Vijay Kutru, 4 people who worked in our center studying multiple sclerosis. So I'm going to end there. I have very fond memories of Rick Tyler, presenting cases to him. I visited his son out in Colorado. Super fond memories of Marty Samuels, and I'm so happy to have him introduce me. And now we're going to get together and have a tuna sandwich in my office. So that's the end, and I'll turn it over for questions.
Thank you so much, Dr. Weiner. I just want to open up the field to questions. Folks are welcome to type questions in the chat or into the Q&A or raise their hand and I can unmute them.
I might ask one while we're waiting. First of all, Howard, that was just fabulous. And I do recommend everybody watch the poker game. I really learned a lot. And those life lessons are ones I'm going to put up on my wall that you shared. I was curious your thoughts about the microbiome in terms of onset of the illness. Like, is this something that is, before people get sick or a result of the illness or what are your thoughts? And I know it might be different by disease.
No, I understand. I think that they can play a role beforehand, quite frankly. So let's take each individual disease. So if you talk about MS, I think MS may start in the gut, and we're actually looking at something called driver B cells. And I think that there may be, I wrote a commentary called the 1-2 punch in the gut, where you can cause reactivity to a myelin antigen and change the immune system. So I think it could happen in the gut in terms of starting MS. Certainly in Parkinson's disease, where you have constipation and all these things. And then some people say that there's gut associated gut or Parkinson's disease, its origin in the gut and versus the brain. So that's very clear. I also think Alzheimer's disease, because you see these bacteroides going up, and it's more in aging. The bacteroides cause more deposition of A beta. Now in MS, the primary thing is the immune system. Obviously in Parkinson's, it's the alpha-synuclein, but I think the gut can do something there. And in Alzheimer's, I think the gut, there's also a leaky gut that happens when you get older, and I think you can affect our ability to clear A beta. Now, as far as ALS is concerned, that's a little more difficult. I begin to think, you know, as I've worked in ALS, it's so tough. It's so tough. And there's all these things that are primarily going on in the brain of ALS patients, as far as mitochondrial dysfunction and all these other things. So I don't know whether the gut can start ALS, but I certainly think it can modulate it. And we really have a lot of data related to that. And so I think that's important. I don't think it starts glioblastoma. I don't know. I think that the glioblastoma and the brain tumors really, I mean, it's such a mess in the brain of these tumors. And I think the immune system is going to, the checkpoint inhibitors made a big effect. So I think we just need to get better but to tell you, a response to these checkpoint inhibitors depends on depends on the microbiome. So depending on what things you have in the microbiome, you do or don't respond to the checkpoint inhibitors. So I think it starts before in MS, in Alzheimer's, and in Parkinson's. I think, in my view, is that in ALS and it plays a contributory factor, and I do believe it'll be able to modulate the disease. And it in brain tumors, it can affect how you respond to checkpoint inhibitors. So I don't know. It's a long answer, but that's yeah. Marty.
Priya, Dr. Srikanth, can I
Go ahead, Marty.
briefly? I wasn't sure whether I was unmuted. Howard, it was wonderful to hear you talk. I read that a negative review in the New York Times, and it's clear that the guy is offended by the fact that a non-professional director and producer could make such a fine film. And he was offended by this. It would be like somebody coming and doing neurology for us, you know, who was an amateur and read about it on the internet. He became very offended, but it's a film worth watching, and that's what I feel. I feel it's very touching and very well done, and it was an honor for you to be able to do Martin Landau's last film, in which he really enjoyed it a great deal working with you. Let me ask you something. It's sort of clinical question. We've known for a long time that when somebody with MS or related illness comes in with an exacerbation, one of the possibilities is that they have an infection somewhere. And it's true of all diseases, of course. An infection can make them worse, but it's particularly striking in MS. And in particular, it's bladder infections with gram-negative organisms, which could easily, and MS, of course, is the disease was much more common in women. And so it's easy to imagine how the gut could be infected with those gram-negative organisms and lead to this problem. And the final part of this is Heiko Brack has obviously been very interested in this idea of transmission of the disease from the gut to the brain. And there's some powerful evidence that's been published in the past couple of years about vagotomy that was done for another reason, protecting people against Parkinson's disease, pretty strikingly in big Scandinavian databases. So I'm asking you, do you think that the route to the central nervous system is via the vagus? Is that the the way in which the toxin, whatever it is, or the synuclein, let's say, reaches the CNS. I know that Stan Prusner is a believer in this and thinks that that the common thread that connects all these neurodegenerative diseases is cell-to-cell transmission of some kind of a prion. So what are your thoughts about that? Why do MS patients get so much worse when they get a little urinary tract infection?
So I think that I think the vagus nerve is one way that the gut connects to the brain. It isn't the only way. It isn't the only way because there's metabolites like the nicotinamide we see in ALS, the way it affects immune cells in MS. If you look at infection in MS, MS of all the diseases is really an immune-mediated disease. I mean, in the relapsing stages anyway. And the immune system evolved to deal with infection, so it responds to infection. MS patients get worse during bladder infections, but they also get worse with upper respiratory infections. People who get the flu, MS patients have more of an attack. So I think that the reason these infections can trigger the disease, bladder infections or upper respiratory infections, is altering the immune system and making it more pro-inflammatory, if you will. The immune system is in a balance. Regulatory cells goes down, IL-1 goes up, IL-17 goes up. That's, I think, how they do it. I don't think it drives it. I don't think it drives it. Now, you have debates with people. There's also this debate now that Alzheimer's is caused by an infection. You know, it's not caused by a beta. That's what people are talking about. But I think that in MS, it's a secondary effect on an immune system that's primed to react. And this is why when you give an MS patient, if an MS patient gets cancer and you give them a checkpoint inhibitor, their MS will get worse because you're releasing these pro-inflammatory cells as when you give the checkpoint inhibitor. I think the same thing happens when the immune system gets activated with a bladder infection or an upper respiratory infection. Interestingly, we didn't see a lot more MS attacks with COVID, but maybe we didn't, maybe there's something different about that.
Thank you, Dr. Weiner. There's one more question in the chat from our inpatient RDA team who asked, do we know the mechanism of how these different bacteria influence the brain and immune system? High Bacteroides firmicutes ratio is associated with inflammatory bowel disease. So curious what the commonality might be.
So I think the commonality is a leaky gut in some of the products getting into the bloodstream and then affecting the innate immune system, affecting monocytes, which then can affect T cells. We just did a study, it's not published, of monocytes in progressive MS, and they tend to have a neurodegenerative phenotype. And the gut can influence these monocytes. Merit, as you know, Oleg and I were looking at monocytes in ALS, and I think they also have this neurodegenerative phenotype that might be related to the gut. So we're just about ready. We have a nice selection with James to look at that in ALS, and we're looking at it also in, we're looking at it in Alzheimer's disease. So I think that's how it works. I think leaky gut, leakage of bacterial products, and those bacterial products affect the innate immune system.
Thank you. I think that's your clock telling us that time is up and we don't have any more burning questions right now, but I'd just like to thank Dr. Weiner and Dr. Samuels and Dr. Sokovich so much for all coming together and hear this wonderful work from Dr. Weiner, both scientifically and outside of the lab, and inspire us all to follow our paths to happiness and success.
Well, it's my pleasure. I want to thank you. I want to thank Marty, Merritt, the Mass General, the Brigham. We've come a long way. We have a long way to go. And I think I'm just thankful that I can be a physician, have great colleagues, and try and help our patients. And I encourage everybody just to stay the course and enjoy life.
Thank you, Howard. Fantastic. Wonderful.